this is what happened. Very hard for him to acknowledge that that's possible until he's there and the computer does it right in front of him, and then he goes, oh. So, I think us being clinicians, we have a somewhat different, I think, brain and a different attitude, and it's very important, though, to develop that kind of a way of looking at things and remembering. Look at what you see, not at what you were told to see. It's very, very important. So speaking of developing resilience, speaking of, we look at something, we know it works. We first of all want to enhance it in our patients. We certainly want to enhance it in ourselves. Okay? Yes?
In your film,
yeah, in the program.
originally said that he didn't care that the commander was killed.
Right.
And then later,
Yeah.
that he cared a lot.
Well, later what you hear is that every night he dreams about his commander's death, and every night he thinks about, the fact that he's the one who alerted his commander to something, and had he not alerted him to that, maybe his commander would have gone back home to his baby, and he himself would have been killed.
So originally he wasn't ready to look at it, when it happened. So he said he didn't.
Originally, he experienced what we all know very well from trauma survivors. Originally, he was completely numb. Okay, let me try to go on a little bit and say, so what we were kind of talking about in trying to understand this whole concept of resilience is whether resilience is or is not the opposite of pathology, right? Can one be resilient and have pathology, pathological symptoms, depression, PTSD, or not? And that is really a question that we must look at it as a strictly empirical question. We cannot have our beliefs about it. It's very important to have beliefs about all kinds of things, but certain things we have to understand are not a matter of belief. There's something to be checked. So look at that. I'm very high tech, as you can see. Okay, this is a basic design for checking any kind of a pathology and how it's related to resilience. Never mind if it's about PTSD, if it's about anything else. You have 4 boxes here, right? You have psychopathology up there. No, there is no psychopathology. Yes, there is psychopathology, okay? And here you have risk factors, whatever it might be. The person was in captivity. The person was in Duvdevan. The person went through some the trauma that you consider as a risk factor, right? Okay, here are the 18-year-old boys going into the army who haven't been through anything yet, right? There is no risk factor yet in their lives. There hasn't been any. They haven't been exposed, if you like the term, and there is no psychopathology, right? What are they? Are they resilient, or is it too early to know? Okay. B is, yes, there is psychopathology. In the absence of exposure to any trauma, people who show psychopathology in the absence of any unusual risk factor, what are they? Vulnerable, right? Clearly, they're more vulnerable than other people. C are the people who have been exposed to a psychopathological risk, something we consider could do it, but they don't show any pathology. They are what is considered resilient by even the most stringent definition, which is the one that says resilient is the one who comes out of it without pathology, right? They are clearly resilient. And vulnerable, or maybe it's the expected trajectory, D are the people who have been exposed to trauma, come out with a psychopathology, and they're the group that we know the least about. They have some pathology, but they also might be resilient. That is an empirical question which we need to answer, and we need to answer that by longitudinal studies. We have to look at these people for a long period of time to see, are their defenses Pollyannish and they collapse? Are they not? Do they manage to maintain a good level of functioning or come back to a good level of functioning and maintain it? Do they manage to be good spouses? Do they manage to be good parents? What do they manage to do when they come to old age like our parents are now? What happens to them then when they reach what Chaim Dasberg, himself a survivor and a very, very good friend of mine, lived right by my parents, calls the age of loss? We all, hopefully, if we are not subject to unexpected terrible things, we will all reach the age of loss. The age in which we lose our health, we lose our social roles as therapists and big machers, the age in which we lose relatives and spouses, and in which our children move out and God's willing are doing very well, but we're not so much part of their lives anymore. It's definitely understandable why Chaim Dasberg calls it the age of loss. And the question is, how do people who have been traumatized before and have shown an extent of resilience throughout previous phases of life, how do they deal with that? And what does that then mean about how resilient they are and so forth? That sharpens the point that there is an alternative explanation that we, I think, need to keep in mind because it's the one I favor. And that is that resilience and pathology are two completely separate, perhaps, dimensions and outcomes of trauma. They are separate. Scores on one don't necessarily predict scores on the other. They can come together and correlate positively. They can correlate inversely, or they can just be different. We're just talking about different aspects of our psychological and general functioning. And like I said, although I favor this explanation, and I think that the lives of Holocaust survivors proves that, because what do we see now? We see people who, despite unimaginable trauma and unimaginably extensive losses, manage to come to a different country, be it here or Canada or Israel or wherever they went, and build a life and have children and work and save money and get themselves somehow financially secure and secure their children. Usually also everybody has to help their children because, the children are, they can't do it by themselves, maybe. So, and manage to marry and manage to have reasonably decent marriages, as opposed to, for example, the degree of spousal violence in Vietnam vet families. We don't see that extent in Holocaust families. And then they come to old age, and having had such a fruitful, resilient, amazing life, many of them all of a sudden become very vulnerable. This past 2 years, 2 huge studies came out, unlike anything before in terms of its width of population included. One was the World Health study. The World Health Organization examined mental health all over the world in a big study, and also in Israel. And there is a component in there that looks specifically at aging Holocaust survivors and shows that aging Holocaust survivors suffer from more anxiety and more sleep disturbances and more depression than others of similar age and so forth. And similarly, Machon Brookdale Institute in Jerusalem that looks at aging, examined all of their statistics about Holocaust survivors in Israel. They have access to government data that covered the entire population of aging Holocaust survivors, 220,000 in Israel currently, and discovered the same thing, that Holocaust survivors in Israel today, aging Holocaust survivors, suffer more anxiety, more emotional distress, more emotional distress and more sleep disturbances than their peers. They are also more isolated and more lonely. Well, guess what? They didn't have brothers and sisters-in-laws and all of that in a, growing organically undisturbed around them. They had fewer to begin with. They certainly have fewer when they grow older, and fewer people in the second generation and so forth. And of course, we know that isolation and a sense of social isolation is one of the most robust components in complicated grief reactions. So if someone is to begin with more isolated and has less peers and relatives around them, when the spouse dies, they're in a much worse position. However, spouses die at this point for Holocaust survivors, right? So here are these people unbelievably resilient for 60 years, not doing so well at aging. What does that mean? Their Pollyannish defenses collapsed all of a sudden? No, I don't think so. I think we have here different life tasks, different requirements and demands for adaptation, different issues that one has to incorporate and flexibly sort of respond to, some of which are closer to the areas of trauma and pose greater difficulties, and some of them, for a variety of reasons, were navigated more successfully. Right. Exactly, exactly. Yes? Yes, yes. Unfortunately, the rate of suicide, which was a hypothesis at some point, following the very famous suicides of Primo Levi and Andrzej, what's his name? Yes, and Jerzy Kuczynski and a lot of prominent survivors of the Holocaust, Jewish and not Jewish. It was a hypothesis, and it has been confirmed that the rate of suicide is higher among Holocaust survivors. Yes. Okay. So let me skip something here. Okay, let me just mention again that it's interesting, in fact, it's interesting that the interest in the concept of resilience, which has been evident in the last, 10 years or so, more than ever, has come on the heels of the great success of the concept of post-traumatic stress disorder. So historically speaking, we had a time in which the concept was that apparently people are very resilient because the mental health profession did not really account by any formal diagnosis for the impact of traumatic events on the well-being of people. So if there's no diagnosis for it, one could say it implied that people were thought to be resilient and capable to bounce back from these events. And indeed, that's the type of thinking that is reflected in, as I said, many of the assessments of Holocaust survivors by their physicians at the time, that, if there was a vulnerability, then obviously it was a pre-existing vulnerability and not something caused by the event. This, of course, left survivors of various traumas, not just Holocaust survivors, but rape survivors and Vietnam vets, feeling very stigmatized, feeling like the fact that they were suffering meant that there was a characterological weakness of theirs that was responsible for it, and not the event that they were exposed to. That led to the diagnosis of PTSD, which was introduced to the DSM in 1980, and said no. Essentially, if I'll be very paraphrase it in a very bold way. Essentially, the diagnosis of PTSD stated that events are pathogenic or can be pathogenic, and that certain events, as I, read to you before, and, the definition in the first DSM-3 where it appeared was slightly different, but essentially that events that are traumatic are events that would cause this kind of a result or this kind of a response in most people exposed, right? Sounds very reasonable, sounds very plausible, however, was not supported by a massive amount of studies that occurred between 1980 and today that show very clearly that not so, that even highly traumatic events leave a minority of people with pathological symptoms while most people recover spontaneously. Okay, so some of the things, let's see, we have an hour at this point. I will very quickly mention some of the main personality characteristics that were found to be typical of resilient people. Namely, I would like to make clear these resilient people, the people who have been exposed to an assault or a traumatic event and show resilience in the sense that they have no post-traumatic symptoms. Okay, so you look at them and you say, let's hear what they tell us about how they coped during the trauma, how they coped after the trauma, what are they like. Let's see what we can know about them in terms of how they function. Just one second. So, several aspects have been written about extensively. I mean, a million aspects have been written about extensively. I did not pretend in any way to try to give you some kind of a more exhaustive list, but some of the big ones, which I think some of the big categories, I will quickly mention. Excuse me. Yes, what did you want to ask? Right, right. You could? Which is why I say we really know nothing about resilience unless we have very good longitudinal studies, not cross-sectional, but looking at this person for the rest of his life to see what happens. Then we will know. Otherwise we can't answer that. Okay. Right. What? Yes, yes, right. Well, what we do know is we have, for example, Vietnam vets that were followed up for 20-something years. We have Holocaust survivors that were followed up. We have rape and sexual abuse survivors that were followed up. But all of them right now, I'm still talking about people. What I'm talking about now is based on people who were exposed to a trauma, and then we look at how they behaved after that throughout their life. This is still only part of the important information, because keep in mind, maybe they behaved this way only because they were exposed to the trauma and the trauma made them already this way. What do we know about how they were before the trauma? That is where we need actually prospective studies, namely things like what can be done by a military, like American military or Israeli military, where you get an entire cohort of people being drafted. You give all of them all kinds of personality assessments, and then you look at those that develop trauma because they were exposed and the others, and you compare them. Then you can say also something about what kind of personality traits did they have before the trauma. Otherwise, you're really talking about personality traits that characterize those who already have been exposed. Okay? So it's different. Nonetheless, based on the characteristics of resilient people who had been exposed to trauma. What we see are several things that are important and important for us as clinicians, because those are 5 categories of stuff to keep in mind. One is self-enhancing biases. Again, not exactly necessarily what we intuitively think of as a good trait, and that's actually a comment I'd like to make before I mention these 5 categories. Some of the things that seem to be very good as modulating trauma and extreme stress may actually be traits that are not necessarily adaptive in other contexts. Keep that in mind too when you look at survivors of traumas. You can look at someone with a somewhat unattractive, off-putting, maladaptive, strange kind of behavior or pattern of behavior and say to yourself, gee, this is really not at all adaptive. I wonder how they came to have that. Well, it's very possible that this pattern of behavior is related to something that actually did help them survive the trauma. It may not make them the most likable person afterwards, but it helped them survive the trauma. And that we have to respect. And when we come to help them modulate the maladaptive aspects of it, now we have to understand that we're dealing with that which saved their lives. So we have to be very careful and very respectful. We can't judge that from our perspective. Yes? Okay, so one of those things are, for example, self-enhancing biases. In general, thinking well about ourselves is something that is considered a good part of a healthy, positive self-concept. Excuse me. However, that is also only true provided that it comes in conjuncture with a realistic appraisal of our shortcomings and our whatever, less than optimal aspects, those of us who have some. And research actually shows us that self-enhancement biases, namely the tendency to see oneself much better and much more positively than even realistically justified, is a very important component of good adaptation to extreme stress. So if you afterwards see someone who's full of themselves or whatever other, derivative of self-enhancement that one can think of, you have to remember, hey, this is the same thing. It's connected. How do I help them work with that so that they don't pay the price for the same type of behavior as a social liability in normative circumstances when it saved their lives? Okay. A couple of other things of that nature that I want to say. Let's see. Just one second. Okay. Let me say, okay, so that, let's say worldviews. That's one that is essentially more of a broader kind of, a positive trait in broader context. Positive beliefs and worldviews about the nature of life and our existence in the world is a very protective factor in all kinds of situations and facets of adaptation. So if we generally believe that the world is a good place, that people are benevolent, that the world is benevolent, that there is justice, that there is order, that there is predictability, that there is fairness, all of these things are very protective. They are also very protective under extreme circumstances. For people who hold negative worldviews, where the world is not just and not fair and bad things happen and people are not benevolent or are malevolent, when something bad happens, it only reinforces their belief that the world is a horrible place. It therefore becomes a part of a cognitive appraisal process of the threat. The threat that they are perceiving is then much greater because it is perceived in the context of, yeah, well, I knew it. The world is horrible and dangerous and people are malevolent and everything is bad. The threat is then perceived as much bigger, much more generalized The sense of competence and possibility of coping with it is therefore reduced. Even neuroendocrinological processes are of course affected by these cognitive appraisals, and in some, adaptation is compromised. So positive worldviews. I will just try to get through a few things, and I will leave us some time for discussion, okay? Is that okay? Okay. Identity, continuity, and complexity, which are slightly different things. The capacity to somehow find a way to maintain one's sense of continuity, of identity continuity, is critical in good adaptation. At the same time, the complexity of identity has been also shown to be a very important issue. So people who have a relatively simple sense of identity, if they go through a trauma that disrupts their sense of continuity, it's harder for them to get over it because it was simpler to begin with, and now it's broken or disrupted, and they just can't quite come to terms with that. People who have a complex identity have apparently an easier time, and I think it makes sense. If you think about it even as a very physical and simple metaphor, think of a very, very big rope that's made of many, many, many fibers, as opposed to a rope that's made of 5 fibers. If the 5 fibers get cut, it's cut. If the thick rope is cut in the middle and half of the fibers are cut, there is still another half to work with. It's broken, it's cut, it's damaged, but there is still something to work with. In that sense, if you like, going back to my personal story, which I would love to do later if we have time, discuss the 3 examples, that I gave you of resilient outcome. My mother's relative, who was from a Zionistic family, very Jewish, very this and that, was also already a professor at the Polish university, very assimilated also. I mean, it was, the 2 things existed. Which parts of his rope were cut, and which parts existed that allowed him to continue and succeed in a Polish university, to even become, at a great risk to himself, a Polish patriot fighting within the solidarity movement for certain changes and improvements in the life of the Polish people. What did he manage to see there as continuity, and what did he sever or lost with the loss of his entire family? It's just a way to illustrate the point. Whereas if someone is a very simple person and loses it, it's harder to connect. Okay, positive emotions, very, very important. There is a growing recognition that positive emotional experiences provide an array of adaptive benefits, both for general functioning and in response to stressful events. So we see that people who have the capacity to experience more positive emotions, for example, they feel they are more resilient to a variety of losses that were looked at, spousal loss and illness and all kinds of things that were looked at. They express less regrets when bereaved. One of the terrible things that people go through when they lose someone and they're bereaved is the feeling of regret. Oh, I should have done this. I wish I didn't move to Kansas. I would have lived more time close to my sister, and now I don't have her. I wish I didn't do that with my husband. And that's part of grieving, is the fact that all of a sudden you are robbed of the opportunity to repair damage in the relationship, to make better. The people who have a capacity to feel more positive emotions don't have as many regrets as other less resilient people. People who experience more positive emotions elicit, of course, much more positive responses from others. right? Truth be told, we all like more to be with people who express positive emotions than people who don't. You know, on Sundays, I go with my daughters to volunteer at a Jewish old age home near our house. Sunday afternoon, we go and we meet with the people there. We do crafts with them. We chat with them. It's a fantastic experience, I think. And there's one guy there, he's 102. Auf mir gesucht, he's completely lucid. He's fine. He lives by himself in his little apartment. And I have not yet, in all of the months that we've been doing this, I have not yet once heard a bad word out of this man's mouth. Not a complaint, not even when he was once sick and with fever. All he has to say is how people were good to him, how lovely it is that we come, what a beautiful day, how important it is that I raise my daughters in this way, how lovely the person is who is in charge of the program, how wonderful the people are in this old age home, how great his men's group is. He just says all the time, he has only good things to say. And you know what? My daughters adore him. They love being with him. How many people can say that they get this kind of a reaction from, young people, and truthfully from everybody? My own sister, who lives, granted, closer to my mother and gets to deal more with the daily issues and burden of being there every day for everything, sometimes says to me, I can't take it, when she sometimes says, kashe. Kashe. Hard, it's difficult. And I say, for 88 years, this woman never uttered the word kashe from her mouth. How hard is it for us, even within the short period of 4 years, to become able to contain some less positive comments from somebody at the end of their lives when all of their unbelievable resilience maybe has really been used up? It's hard for us. It's hard. It's natural. So people who experience positive emotions and express positive emotions elicit a much more positive reaction from others, which again puts a whole process in place whereby they're less likely to be isolated, they're less likely to be lonely, and they also tend to engage less in rumination, which is related to the regrets that I said before. And rumination is a very powerful and intractable aspect of complicated grieving. It's not a good thing for adaptation after loss. Rumination is a good thing to stop. Like someone showed me this little video about a stand-up comedian. Did you see it? And he just goes to the patient goes, I have this, and I do this, and I do this, and it just goes, so I'll tell you what you need to do. Stop it. Yes, that. So, right, rumination is something that we need to stop. We need to help our clients stop, and we need to use whatever methods we have to stop that. Okay, and last but not least, the capacity to benefit or to derive positive comfort from memories. That's also a very important thing, which seems to help people or seem to characterize resilient people and their reaction to loss. I think that this is something for us to also remember, because as clinicians, especially ones dealing with older people, survivors, or other victims of loss, sometimes, again, we are blinded by partial comprehension or partial knowledge of our models, the models that our field upholds. And we think that in order to grieve in the right way, people have to be talking and processing and resolving their anger towards the dead, their regrets, their whatever. Well, what did I just say? I just said it appears that the more resilient people actually don't do that. So again, it goes against some of our concepts, and we need to remember it and we need to appreciate it, especially with older people, and especially with older people who have been through trauma. My mom gets visits from a very nice young social worker who works for Amcha in Jerusalem. And my mom is a really friendly woman. And my mom says, Irush, every week she comes to me and she wants to talk about the Holocaust. And she says, Irush, I don't want to talk about it with her anymore. I don't want, but לא נעים לי. לא נעים לי. Unpleasant. I don't want to offend her. She's such a nice lady. But every week she comes, she wants to talk about the Holocaust. And we have to understand that the findings do not support, and this is perhaps almost where I will finish this part, and I'll tell you what is the other part that we might touch upon or not, and I'll leave some time for discussion. We have to understand that the findings, the empirical research findings, do not support the view that bereavement and grief work have to look like we thought. They do not support the assumption that in order to do it well, we have to show a lot of distress and we have to show a need to ruminate and to process regrets, and none of that. It's very possible that you see someone who lost somebody and they have no need to do that. They're not really showing incredible distress. They don't need to process what happened between them and all. They are okay, and it's not because they're denying it or avoiding it. It's just their way of coping, and that's okay. And in fact, some of these things are things that we might keep in mind, totally different than the, psychodynamic focus on going after, unresolved issues. Some of these traits that I just told you about, we might keep in mind as things that we actually want to tailor certain interventions with these things in mind, that actually we want to be able to help our clients to have positive emotions, to derive comfort from memories. Because one of the things that differs between resilient people and not resilient people after loss is apparently that the resilient people, some of the thing that differentiates between people who are resilient, namely they don't show any kind of breakdown after loss, they just kind of continue unchanged, as opposed to the people who are on the recovery trajectory, which means they have a bad time and they come out of it, is that the resilient people seem to be able to derive comfort from good memories continuously, whereas the people on the recovery trajectory gradually lose the capacity to derive comfort from good memories. It's almost as if the resilient ones can continue to hang on to good things and derive emotional support from it, whereas the other ones lose it after a while. So those are things to keep in mind. So for example, when the nice lady from Amcha will come to my mother next time, I will try to say to her that, research actually supports the impression that especially in the old age, it's better for the affect of the patient to be helped to speak and to hang on to good, positive memories and experiences rather than talk about their negative ones. It actually is research born that maybe up to a certain age, maybe we need to rework the negative, maybe we need to, but certainly in the old age, something else is better for affect regulation and for helping people deal with the inevitable depression of old age, and certainly with the almost inevitable, it seems, reawakening of post-traumatic delayed depressive reactions. Okay, I could stop here with this piece, and I'll tell you what I thought. We could either talk for the next half hour, or of course I could tell you some other things which I have and which are interesting, or I could tell you a little bit about particular interventions. that I could show a small piece of. Okay, I'll tell you what I think. I haven't actually had a chance to talk with Arlene about it, but I think that two particular interventions that I find helpful. I am actually psychodynamically trained, as you well know. I am essentially a psychodynamic psychologist. I like very much a lot of the self-psychology theoretical framework. But I am, or I would like to think of myself also as a very practical woman, and I like everything that works. So many times I use other things from cognitive behavioral or some other technique or whatever it is that has been shown either by my experience or by the literature to work. So I thought that I would go over with you briefly some of the things that I do and what I think about them, but two in particular, which are exposure, cognitive behavioral exposure for the treatment of specific traumatic events, and the imago dialogue, which is another thing to actually strengthen relationship and yeah, let's put it this way, strengthen the relationship helps very, very much to break down all kinds of bad cycles in the couple or in the family, which again, if you recall, as I don't know if I managed to say, no, I didn't manage to say, that was in the part that I have a little bit later. One of the things that is, I think it was sprinkled through my talk, but one of the things that is very, very critical in allowing trauma victims to heal is the degree of social support that they have, which means family attitudes and, of course, the attitudes of the environment in all of its growing circles around them. Just one sec. And therefore, it is critically important, even if you come from a psychodynamic orientation like me, where, you know, there's always a little voice in my head that goes like this when I say, yeah, bring your mother and your father and your daughter and your everybody, bring them here to my office, which is not the way I was trained in a certain way. But I definitely think that whatever we can do to improve the understanding and the relationship, both the understanding of the other people in the family of what it means to be a trauma victim, what do they deal with, psychoeducation, and improvement of the relationships in the family is a critical element in our therapy of any trauma victim. To treat a trauma victim in a vacuum is ludicrous. Okay? I mean, not that it doesn't have its own benefits, but at least we have to understand its limitations. So I thought that these two techniques, which are highly, highly routinized techniques with, of course, once you get good at it, you sort of play around and you do your own variations, but hopefully not too much, because it's really, those are routinized, very good techniques with very good evidence-based, you know, studies. Those perhaps deserve a session in their own right to really teach the group that wants to learn how to do it, and with examples that are, you know, with role playing or with real examples or whatever, to really teach people how to use the dialogue, how to use exposure techniques. So those I will just have mentioned in the way that I mentioned it so far. The other thing that we know is that one of the most powerful predictors of post-traumatic chronic on course, the one that stays and really makes people's lives much more difficult on the long term, is the initial degree of distress after the trauma. That is a critical element, and therefore, despite the very bad rep that critical incident debriefing has gotten in the literature for good reasons, I am a trauma specialist that gets called by this national organization that pools a lot of trauma specialists across the country nationally, and calls us when something really bad happens in our vicinity. It's true that you have to be very careful in what you do. When you intervene with people, right where it happened, right when it happened, you have to know what you're doing. You do not want to encourage abreaction that will traumatize and re-traumatize everybody else. But what you do want to do is you do want to provide immediate opportunity for good dissemination of information about what happened. We know that information that is adequate is very, very important for the cognitive processes that occur immediately in our attempt to understand what happened, why happened, what did I do the right, could I do differently, who is to blame, who's not to blame. Very important to disseminate information appropriately and adequately as soon as possible. Very important to psychoeducate. So give people an idea about what it is that they're experiencing and why they're experiencing it, and normalize it without sort of inviting it and programming them to have all kinds of things, but just a very matter-of-fact, supportive, down-to-earth, this is what we know, you're not alone, you're not going crazy, this is what to expect. Also very important is to create the group setting which allows people to see that, it's legitimate to talk about it and it's other people who are feeling this way too and not just them. It's very important to use it for the purposes of immediately giving people ideas about how to stress manage. Basic things, how to do it. You need to make sure you eat well. You need to very much protect your sleep cycle. No, you can't stay up just because you go to sleep. And if that's your problem, go get sleep medication. Do not drink alcohol, even if in normal times you do, because this interferes with the processing of it. Get as much exercise as you can. Be with people that are close to you as much as you can. All of these relaxation techniques, did I say? We can teach them relaxation techniques right there on the spot. And most importantly, or not most importantly, no. This is most importantly because these are the things that allow 90%, those 90% that will not go on to develop post-traumatic stress, to use what we tell them and what we give them in order to, get better with it by themselves. But also important is for me to be there to recognize the 7.8% or the 8% or whatever it is, less than 10%, but nonetheless, who are experiencing intense reactions and who will go on to develop possibly post-traumatic stress disorder if they don't get help. So this is what I do, and that's one thing that you can do too in different ways, in terms of within your clinics, as a service, as a service for the individual that you come to see. Whatever form it is that you're doing, it's something that some proficiency with would be possible. That's, again, whatever of these things that you think you would like to get some specific training in, I think you need to tell Arlene and, we can talk about it. The other thing is the testimony. I am part also within the trauma group at Yale. Yale University and Dr. Laub were one of the pioneering organizations to create the video archive of testimonies of Holocaust survivors a long time before the Shoah project that was financed by Spielberg. And I can tell you that I think, and it's not just me, again, there's studies that are very supportive of it, again, from all over the world, from political prisoners in Chile and in Argentina and all kinds of places, that giving testimony, the formal act of giving testimony is a very therapeutic process in and of itself. And that means not just sitting alone with a therapist, but documenting it, videotaping it formally and well, and in a very, formalizing the situation as best you can, having the family members there or not, depends on the survivor while they're giving the testimony, But the more formal the situation is, the better. And I can tell you from experience, one of the studies that we did was the study of the most chronically ill, psychiatrically chronically ill patients, Holocaust survivors in Israel. They were, people who were hospitalized for like immediately after the war or a few years after the war for decades, without really essentially any functioning, normative functioning in between. And when we first did it, I said to Dori Laub, who I like very much and I can be quite open with, I was like, you're nuts. I said, we will learn a lot from speaking with these people, definitely, but we will not see any improvement in their condition after 40 years of chronic psychiatric hospitalization, not to mention the kind of treatments that were available 40 years ago, including Haldol shots and bilateral ECTs and all kinds of things that we know are very damaging today. Well, I have to tell you that to my shocking surprise, we did not see an improvement in many things, but what we did see was an improvement in the avoidance cluster of their PTSD symptoms, which is critical, because if the patient now is willing to go with the group for an outing to the nearby mall, as opposed to constricting themselves only to the hostel, then you know what? For someone who lived their entire life, has lived their entire life, and will live their entire life in the hostel, it's a mighty big improvement. Not to mention that once you manage to introduce a change in the avoidance behavior of a PTSD patient, you open the door for many new positive experiences, which have their own counterbalancing effect then. As they accumulate, they have a counterbalancing effect again on the avoidance tendencies and also on a lot of other things. They begin to have some new positive experiences as opposed to not having them and having only the PTSD experiences, right? So the numbing element in the post-traumatic syndrome is a critical one, because having worked with people of all kinds of PTSD types all this time, I can tell you people in my experience have the capacity to deal with terribly, terribly horrific intrusive symptomatology and with a very high level of chronic hyperarousal. But people can't live if they are at the mercy of severe avoidance tendencies. If they have to avoid everything, either emotionally by constricting or physically by avoiding places, people, triggers, things, they can't live a life that's worth living. It really, really interferes not just with their subjective experience and with their level of distress. It literally limits what kind of new experiences they can have in the presence. So testimony is a very important thing to bring into consideration when we're treating a trauma survivor. And there are ways to go about it. Either within home you can create such a service, or there are places that you can go to, send the survivor to, or not just the Holocaust survivor. Okay. The other thing that is very important is, let's see, I have only 15 minutes. Okay. All right, so I'll just speak about one more thing, and with that we will close, and I will leave 10 minutes for discussion, if that's okay with you. One of the things that I didn't get to talk about, I did get to mention a little bit all the cognitive appraisal processes that go into what helps people see a terrible event as less threatening, more threatening, how important it is, what goes into that, and also in the way people review it and think about it. So there's a lot of cognitive appraisal issues and processes involved in how we respond to a traumatic stressor. what we have neglected, in my opinion, a lot in the field is something that I see all the time with trauma survivors, and that is not, let me say again, what we have stressed and emphasized and studied a lot are cognitive ways of making meaning and finding significance in the traumatic event as a way to reestablish continuity and self-coherence and all of that. Cognitive. I have to say part of what the previous presentation was about was also very cognitive. It's about what we narrate, how we narrate it to ourselves, how we reestablish a narrative, and all of this is very, very important. But you know what? There are times when survivors have to deal with something to which there is no possibility to find a cognitive, meaning-making explanation. If a child of somebody was abducted on her way from school and found dead after unimaginable kind of torturing, a good kid, and this is the type of stuff that I work with when I see children, parents of children who are murdered, yes? There is no benefit that can be taken out of the experience. There is no cognitive process that can make sense of it. There is nothing that can be done cognitively with that to reestablish some kind of coherence and continuity in the way you looked at the world, in anything at all. There, I have to tell you, I fall back to my experiences with Holocaust survivors and with PTSD casualties of the army in Israel. And I say there is an element that we forgot a little bit, and that is active or meaning-making through action. Meaning-making that is not at all cognitive, but is through action. It's the intense occupation, the intense focus on that which matters most in action. It's a performative, if you like, process. It's not a cognitive process. And that's what many of our parents did when they are described in the literature as having worked 3 jobs and done this and this and that, and not being able to talk and be with their children, but being very busy doing and providing and building and continuously in the doing mode. That is the performative mode of meaning making. When you cannot make meaning of something cognitively, because you can't look at the Holocaust and say, well, the good thing that came out of it, a little bit of it we do in Israel, a little bit of it when we say, and I say it with definitely, I definitely feel this, the good thing that came out of it is that we have the State of Israel. But other than that, what else can you say? What else can you say? How can you make sense of our existence and of the world after that? What we can do is we can make performative sense. We can focus on that which is most important and do that and build that and focus on that. Sure, it has a psychological price. Sure, it doesn't make for people who then are very relaxed and able to talk and, access a very meaningful, internal dialogue sometimes. But hey, they were able to build the State of Israel, and they were able to participate in a very significant way in social adaptive functioning in this country, and they were able to make us. So it works. And this is what I do when I work with some of the people that I see. And when I was younger and I was trained in the military academy in Israel to work with officers, as I say again, I was younger. One of the methods that we used was a very active method. It's also used by some units in the American military now. It had to do with taking them into groups, the people who were PTSD casualties, and putting these groups through a very intensive, short therapeutic course that involved first a few days of exercises that are very similar to what people do in the Army in the basic training. So all kinds of things that you have to accomplish. You have to somehow get across, I don't know, a very, very tall wall with, I don't know, a piece of wood and a string. And you have to use collaboration. You have to come up with a solution. You have to trust each other. You have to physically put each other on each other, pull each other, push each other, hold your butt and push it up. All of those things that are very similar to the atmosphere in which they were before the trauma, and also create a sense of unity and mutual trust on levels that are not verbal and not cognitive. And after that, we use all kinds of enactment, dialogues, role playing of the trauma in a group setting, which is again a very performative thing. Lastly, I will say for my patients who can and want, one of the ways in which people sometimes find meaning in the performative sense is, some people, it's very important to remind them. The most important thing for you are your children. And if you don't function well enough for your children, you give them, the remaining children, the ones who are alive, you give the murderer them too. You give the murderer the power to damage them as well. So fostering the functioning with the children, and that's where I wanted to show you, but alas, time has run out, a very, very moving video with my work with a group of widows, me and a lot of other therapists in an effort that was initiated by Dr. Bibi from Columbia University. They got a grant. We work with widows of September 11th who had children born to them after the husbands were killed. So I want to show, I'll only show a few minutes. I don't have to show the whole thing. But the point is that I wanted to make a point, and it escapes me. Just one second. Yes, protecting the children and protecting appropriate and adequate, good enough parenting. If we learned anything from Holocaust survivors, is we learned a lot about some of the functions that are damaged by trauma. If we learned anything from Vietnam vets, we learned a lot about that too. And what we do is we do therapy, individual therapy with the mothers. We also have a lot of group meetings for them so that they feel the support of the other doves with broken wings, as my previous presenter said, and how it's possible, and how, because really people who are traumatized can only speak truly to another who's been traumatized, which is another thing about the trauma field. It's very hard to be a good trauma expert if you have no clue what trauma is. Personally, it's hard. It doesn't come across as convincing. However, as I said, most of us do have some experience. In any case, what we do with these women also is periodically they are invited to play, free play with their child, and that is videotaped. It serves, of course, as research data for Dr. Bibi and her group, but what it also does is after the video is taken, it's analyzed with the mother, and all kinds of things that have to do with making her aware of how available, not available, attuned, not attuned she is, what are the themes that her child is bringing into the dialogue. And I mean not only the verbal dialogue, I primarily mean the implicit dialogue between them and how she responds. How mother, by going, there was a play that I just saw about transmission, and in which the grandma, whenever the daughter the granddaughter tried to come to her, would do just this slight, little body language, little aversion of gaze that are very powerful communications in the dialogue about what's acceptable, what's not acceptable, what mommy can tolerate, what mommy cannot tolerate. And doing that with the mothers over these few years, I can tell you, has led to tremendous changes in how these women are with their children and also to how they are with themselves, because it gave them a lot of support in their parenting, but also in how they allow themselves to include a lot of aspects of their emotions in their dialogue with themselves. So that's another thing that I wanted to talk about. Here is a little bit of the video. I guess we're not...
Prime time. For the nation, it's an anniversary. But for an irresistible group of children, tornadoes on tiny legs, this September is a time of new beginnings. The first day of kindergarten, new friends, and a chance to ask again all those questions that their mothers feel right in the center of their hearts. These are the children born to mothers who were pregnant on 9/11, when their fathers were lost. We are grateful to be part of the family gathering, an extraordinary reunion, as we try to find out what 5 years can do to the memory of old love and new love on the horizon, and above all, to the children whose laughter and hope reaches straight up to heaven. We first met them 5 years ago, coughed out, cooing, laughing, howling. Every little heartbeat a reminder that life will go on even when mother
Excuse us, it's not moving. Just 1 second.
And that babies who look so eerily like the fathers they'll never meet. The firefighters, businessmen, policemen, all walks of life, some of them husbands who never had a chance to learn that they were going to be dads. As the 5th anniversary of 9/11 approaches, we gather again in the Palm House of Brooklyn Botanic Garden. Outside, it's pouring rain, but in this room, the sun shines. And the babies? Just look at them now.
So how old are you? Is that many? Are you sure you're not that? You're 4. You're 4. 4? What is your cheeky? Did the tooth fairy come?
In her imagination, the tooth fairy and a gentle place where Daddy lives.
The fire department. 4095. That's your dad? Your dad was a firefighter? He did. He did. And let me see.
He's in heaven.
He's in heaven? Yeah.
With the angel.
Mm-hmm.
What is in the heaven? The angel.
Is it okay that he's with the angels?
Yeah. That's okay. But he's the angel fire.
An angel fireman. So small, she says, she can carry him with her everywhere.
Right, can you tell me up in heaven?
And then when I was a baby a long time ago, he died. And then he crashed into his building.
Yeah.
And then he died. My dad's name is Kevin and I'm Kevin.
And if the babies look like their daddies, stop and look at the faces now. One mother said, "You are the kiss your father left behind." On 9/11, Jackie Milam and her husband were both at work at the Pentagon when the plane hit. Jackie was pregnant with little Ron.
As of late, there's been quite a lot that he's asked me about my dad, or I want my dad.
With age come questions and comparisons. At preschool, he sees other dads picking up their kids.
When he gets upset, I want my dad, I want my dad. And I just try to go back. If his daddy could be here, he would be here for you. I promise you that.
Holly O'Neill has learned that old answers aren't enough for a 4-year-old like Sean.
She said, what happened? What happened? And I sort of gave her a very simple chronology of how it all happened. married and we went on our honeymoon, and when we came home, you were in my belly and we were both really excited, and there were some bad men, and they set a fire to the building that your dad worked in, and it said, and you know, he went to heaven that day, along with a lot of other daddies and mommies. And she said, how come I'm the only one without a daddy? And then I just tell her, actually that's not true.
Oh, you were named after your dad, weren't you?
I think that's the most important thing I can give her right now, is to see that she's not alone and she's not the only one.
Okay.
It is one of the reasons the mothers want to gather together with their children. These members of a sorority they never wanted to join. And every year we're together, we can't help but feel that all the fathers, somehow or somewhere, looking down, like the most beloved, protective, imaginary friends.
Wait. Okay. So, as you can see, there's a tremendous amount of support that one gets from being together with the people who are the only ones who can really kind of understand what you're going through, because they're going through it too. And I can tell you that some of the women, you know, initially when their children were younger, and they would, they would build a block building, and they would say, this is the building where my father worked, and then they would go, poof, and, I remember one mother, she just couldn't take it, and she was like, oh, don't do that, and why are you doing that? And, and it takes a while to allow for these things to be viewed as part of the dialogue. What are you telling him when you're actually telling him that he's not allowed to express his anger and his fear and break this building? And what are you saying, and how much more inclusive her dialogue became with this child and with herself about a lot of other things, and with other people, how much more inclusive of all kinds of feelings and all kinds of things that need to be included for the emotional dialogue of the trauma survivor with their children to be such that less damaged ways of relating will develop, less damaged than some of the ways of relating that we did see in Holocaust families and Vietnam vet families.